Today we will be discussing CVA. You are learning outcomes, program and course objectives for this topic. So I expect you to utilize your intellectual and practical skills to synthesize knowledge of nursing and liberal arts and science as a basis for professional nursing practice. You will identify and apply your knowledge of the pathophysiology of CVA, as well as utilize the nursing process and clinical reasoning skills to care for a patient that is diagnosed with a CVA. And you will demonstrate your human caring ability and take accountability as a professional for caring for your adult client with a CVA. Our macro concepts include safety, adaptation, roles of the professional nurse, oxygenation, ventilation, circulation, and tissue perfusion. So let's discuss our student learning objectives. First, we will discuss one causative factor for both a CVA as well as a transient ischemic attack and the significance of both of these diagnoses. We will differentiate between ischemic and hemorrhagic strokes. I will mention at least 5 clinical findings for a CVA, and we will discuss the unique symptoms of both a right and left cerebral infarct. We will discuss medical and surgical techniques to prevent reoccurrence of a CVA, as well as the nursing care of both a hemorrhagic and ischemic cerebral infarct. It's important for nurses to understand exactly their role in caring for these patients. And therefore, it is also important to identify nursing diagnoses as well as interventions that go along with these diagnoses to care for a client diagnosed with a CVA. So let's discuss some causative factors and the significance of a stroke. CVAs or strokes are very prevalent in our country. It is the leading cause of disability in the United States. CVAs are the 5th leading cause of death in the United States. So you are guaranteed to care for a patient diagnosed with a stroke during your care. Either it will be an acute stroke or past medical history of a CVA, where they may have some residual effects from that CVA, or they may not. So let's discuss what a stroke is. So a stroke goes by several names, and I believe this is very important because in report as a nurse you may receive cerebral vascular accident or CVA. When you read the chart, it may state a cerebral infarct. And if you talk to your patient, they may say, the doctor explained I had a brain attack. So I want you to leave here knowing that stroke, cerebral infarct, cerebral vascular accident, CVA, brain attack are all the same diagnosis. It is important as new nurses to recognize that, because when you enter a patient's room, it's important to know exactly what you're dealing with so that you can prioritize your care. You can prioritize which patients need to be seen first. And in the event that you are unsure of a diagnosis, then that could jeopardize the care and the life of your patient. So I want to explain to you cerebral infarct. It means the death of brain tissue. And as we get more into what a stroke actually is, what actually occurs, you will understand why cerebral infarct is the official name for a CVA. A stroke is caused by a lack of blood flow to the brain, which results in damaged nerve cells. The opposite side of the body is affected in relation to the cerebral damage of the brain. This is important to know. So if they have a right CVA, they will have left-sided weakness. They will have left-sided neglect as far as the cure or even recognizing, visualizing any safety hazards. So this is very important as a nurse to know that the opposite side of the body is affected by the CVA. Let's discuss risk factors. So there are risk factors that can be modified, and there are risk factors that are not able to be modified. So let's talk about the non-modifiable risk factors. So age plays a factor. If you are 55 or above, you are at higher risk for a stroke. Race plays a factor. Minorities, especially African Americans, Hispanics, and Native Americans, also at higher risk for a CVA. Medical conditions such as AFib, clotting disorders like hemophilia, sickle cell anemia, lupus, past medical history and family history of MIs, strokes, and TIAs also play a role, as well as gender. Males are more prone to have a CVA prior to the age of 55 than females. Those risk factors that can be modified are cardiovascular disease, such as hypertension and hyperlipidemia. These diseases can be managed from diet, exercise, and medication compliance. Lifestyle changes also can decrease your risk factors. So stopping smoking, decreasing your alcohol intake, and stopping any substance or illicit drug abuse, reducing your weight. Obesity is a risk factor, as well as a sedentary lifestyle. So just getting up and moving at least every 30 minutes is also good, just to increase the circulation in your body. And sometimes certain medications are placing a patient at higher risk for a CVA. So birth control pills or any type of hormone replacement therapy will place an individual at a higher risk for a CVA. Let's discuss diagnostic testing for a CVA. Most acute care settings have a timeline mapped out for their stroke protocol, and it is essential for medical staff to identify the type of stroke the patient is having to determine the proper treatment. So there is a definite timeline associated with the identification of the type or category of the stroke. A CT scan is the most common or the first test that is done for a suspected CVA, but also an MRI could possibly be used as well to detect whether the CVA is ischemic or hemorrhagic in nature. There are several types of tests that actually will give information about the condition of the arteries. So one of these tests are Doppler ultrasound of the carotid artery, in addition to echocardiography, which evaluates the blood flow to the brain, and the cerebral angiography, which gives a picture of the blood flow through the vessels and allows the size and location of blockage to be reviewed. And last but not least, a lumbar puncture may be done if, in fact, the CAT scan or MRI indicates a hemorrhagic CVA is possible. Therefore, they would do a lumbar puncture to detect whether or not there is blood in the spinal fluid. And there's a slew of labs that will go along with this diagnostic testing. Mainly, they are testing for clotting factors. They're also testing for any heart disease or hyperlipidemia, as well as electrolyte imbalances and renal function. So let's discuss the types of strokes and their prevalence. So there are two main types of strokes. One is hemorrhagic, the other is ischemic. 15% of CVAs are hemorrhagic strokes, which is a brain bleed that damages the brain tissue due to the increased pressure in the brain. There are two types of hemorrhagic strokes: ICH or intracranial hemorrhage, SAH or subarachnoid hemorrhage. And ICH is caused by bleeding within the brain tissue itself and is a very life-threatening situation. SAH is caused by bleeding in between the arachnoid space and the pia mater, which is directly outside of the brain. Now, 80% of the CVAs are ischemic in nature, and they are called ischemic strokes. There are two different categories of ischemic strokes. So first we have thrombolytic, and a thrombolytic stroke is the formation of a blood clot that partially occludes an artery that is already clogged with fatty deposits of plaque. This clot blocks the blood flow, resulting in damage to the brain tissue. The second type of ischemic stroke is embolic or embolus. Embolic is an embolus or clot that travels from another part of the body to the cerebral arteries, causing an occlusion or blockage of blood flow. This type of CVA is the most frequent type, and it is usually caused by arrhythmia called atrial fibrillation, which is when the heart is ineffective when it contracts, and therefore clots usually form because the blood is flowing much slower rate and it is a stagnant pace. Then last but not least, we have TIA or transient ischemic attack, which is responsible for at least 5% of the CVAs. So TIAs are temporary decrease of blood flow to the brain, and they usually occur very suddenly. So it is important to recognize that these signs and symptoms of a stroke are similar to Bell's palsy, but you must understand that Bell's palsy does resolve itself when a CVA will not, as well as it is very similar to hypoglycemia. Now, that's not mentioned here on this slide, but it is very important for you to know that a thorough investigation of their medical history, as well as possibly just checking their blood sugar as part of your assessment, is something that is warranted, just to make sure you're not treating someone that is hypoglycemic with the treatment for a CVA. So let's discuss what a TIA really is. A TIA is a temporary neurological impairment resulting from cerebral blood flow being interrupted. Now, there is no residual effects from a TIA. A TIA can last from a few minutes up to 24 hours, and it is resolved. There is no residual effects, as I mentioned previously. But a TIA is a forewarning that a large-scale CVA will occur in the near future. So it is essential that this patient receives medical care and follows up with the cardiologist as well as their primary doctor in neurology, just to make sure that this patient risk factors are reduced to help prevent a full-blown CVA. Because at least 1/3 of Americans that experience a TIA will have a CVA, a full-blown large CVA in the near future. Types of strokes. So let's just review side by side ischemic as well as hemorrhagic strokes. An ischemic stroke occurs when a clot or a mass clogs the blood vessel, cutting off the blood flow to the brain cells. And in this diagram that I have here, you can see that the artery wall is damaged, then plaque starts to accumulate, then we have an increased amount of plaque accumulating, and then the artery begins to narrow. And then we can either go in one direction or the other, where the artery is occluded, partially occluded, and blood is slowed and blocking that artery's flow, or a clot can form right there, occluding that artery along with the plaque. Then we also have the hemorrhagic stroke, which results from a weakening of the vessels and a rupture and bleed into the surrounding brain. The blood accumulates and compresses the surrounding brain tissue, causing the brain tissue to die. So in both instances, the brain tissue does suffer impairment of oxygen and nutrients, and death is usually a result of this brain tissue being deprived of the oxygenation as well as the vital nutrients such as glucose that is needed. And then there's also a buildup of lactic acid and other by-waste products due to the injury to the brain tissue. Let's talk about some fun facts concerning ischemic strokes. Ischemic strokes occur more frequently than hemorrhagic strokes. This is something that we really should hone in on, as well as the occlusion of a large or small vessel in the brain can occur and cause an ischemic stroke. Embolic occlusions can be caused by fat, a blood clot, or an air embolism, which sometimes, if the nurse does not prime the IV tubing, we can introduce air into the circulatory system, producing an air embolism. A major factor in the development of emboli or blood clot is having atrial fib. A patient diagnosed with atrial fib is at higher risk for a stroke, definitely higher risk for a DVT or a clot, which then makes them at higher risk for a stroke because their heart is not pumping efficiently. And cryptogenic refers to a CVA of unknown origin. So please keep that in mind as well. Sometimes there is no rhyme or reason to why a patient has suffered a CVA, but it does occur. So what exactly happens with an intracerebral hemorrhage? A vessel ruptures from a weakened wall, which is called an aneurysm, and this rupture causes bleeding in the brain tissue. An aneurysm and intracerebral hemorrhage is usually caused by hypertension, uncontrolled hypertension. Sometimes the hypertension or the elevated blood pressure causes tiny arteries in the brain to rupture, or it could be a weakened wall, such as an aneurysm that ruptures. Either way, the release of this blood in the cranial cavity increases the cranial pressure, causing cerebral edema, and displaces the brain tissue, depriving the brain of the nutrients and oxygen, causing a cerebral infarct or death of the brain tissue. Some of the causative factors include the use of brain thinners. We already discussed hypertension and aneurysm as well. It could be caused by head trauma. It could also be caused by a bleeding disorder such as hemophilia, sickle cell anemia, thrombocytopenia, or a tumor that is highly vascular in nature. The causative factors we discussed for intracerebral hemorrhage are the same causative factors for a subarachnoid hemorrhage. So let's just discuss the etiology of a subarachnoid hemorrhage. So it is caused by a rupture or of an aneurysm, and the bleeding occurs in the subarachnoid space, which is the space between the arachnoid and the pia mater, which increases the pressure in the brain cavity, compressing the brain tissue, which causes a death of the brain tissue or damage of the brain tissue from a lack of nutrients, a lack of oxygen, and a buildup of waste products due to the injured tissue. This decreased perfusion to the brain tissue causes the cerebral artery to constrict and causes spasms and results in cerebral ischemia, or a lack of blood flow to the brain, causing neurological dysfunction and a decreased level of consciousness. Now that we have a basic understanding of the disease process of a CVA, and we have reviewed the causative factors and the significance of a CVA and the variety of categories that fall under this diagnosis, we will move along to clinical manifestations of a CVA. Signs and symptoms of a hemorrhagic stroke. So I do want to emphasize that a hemorrhagic stroke has a rapid onset, and this is important to know because we must identify whether the patient entering the acute care setting has a hemorrhagic stroke or an ischemic stroke, and we must identify that immediately. It determines the treatment for this patient. So some key signs are it is a rapid onset versus ischemic is a gradual onset, as well as this patient will be experiencing a headache like never before. They will also experience nausea, vomiting, sensory changes. They may be lethargic or confused. They will have sudden weakness or numbing of one side of the body. They may become unconscious and have a temporary loss of vision, or even possibly seizures, slurred speech, fixed or deviated pupils, and an abnormal posture from their hemiplegia. So let's discuss the clinical findings of a right and left cerebral infarct. A patient with right-sided brain damage, or CVA, will present with a decreased sensation and increased weakness in their left side of their body. They may appear to be paralyzed. They may have neglect of the left side of the body, as well as visual impairment on the left side of the body, their visual field. They may be impulsive, have a short attention span, and have impaired judgment. So let's talk about a patient with left brain damage. Some things are similar, such as they will have the weakness on the opposite side. So they will have weakness on the right side of the body, as well as a decrease in sensation. The right side will may be paralyzed, but they will have a speech impairment or language impairment, which could be aphasia. There's two types, expressive and receptive, or they could have dysphagia. Their performance may appear to be slower than before. They may move more cautiously. These individuals are aware of their deficit, and because of their heightened awareness of their deficit, they have mood swings, are often depressed or anxious. So let's discuss the medical management of a CVA. Transchemic attack facts. So we have already discussed what we can expect with a TIA. So let's talk about some of the clinical findings, which is temporary lightheadedness, confusion, speech disturbances depending upon the side of the brain that's affected, vision loss or vision changes, as well as numbness, weakness, and loss or impaired muscle coordination or paralysis. So one of the clinical assessments that can determine a TIA is auscultating the carotid artery. If a BRU is noted, then it is quite a possibility that a TIA is pending or has occurred. In addition to that, I wanted to mention that a TIA is an emergent situation, and it is important that the clinician call 911 immediately to have this patient evaluated for a full-blown stroke. Medical management of ischemic stroke. So first, control of hypertension, losing weight, stopping any smoking, tobacco use, alcohol, or illicit drug use can help prevent ischemic strokes, as well as compliance with medications for hyperlipidemia, dysarrhythmias, as well as prophylactic drugs such as anticoagulants or antiplatelet drugs to help thin the blood and prevent clots. Some examples of these medications are aspirin, Plavix, Coumadin, and TPA, which is an emergent drug that is used to manage a CVA within the first 3 to 4.5 hours, and we'll discuss that in more depth shortly. Also, surgical management is an option as well. So angioplasty and stent placement, as well as removing of a clot from the carotid artery may be an option as well. TPA. So what exactly is TPA? TPA is only to be used as an emergency treatment for ischemic stroke. It cannot be used with hemorrhagic stroke. That is very important to know and to remember. This is the only FDA-approved treatment for an acute ischemic stroke. That's why the timeline is very important, because this drug must be administered within 3 to 4.5 hours from the onset of symptoms. The blood flow for the cerebral vessels can be restored to ischemic nerve tissue by using IV TPA to dissolve the blood clot. TPA is also known as the clot buster drug, and there are certain criteria that the patient must meet in order for the patient to be a candidate for TPA. Inclusion criteria includes a measurable neurological deficit, and you can use several different neurological tools. Your textbook mentions NIHSS tool, but your facility may have a different tool in place. No hemorrhage on the CAT scan of their head. And the symptoms, onset of symptoms were within the time frame allotted between 3 and 4.5 hours. The symptoms present for 30 minutes, not rapidly improving, which would indicate a TIA or some other disease such as possibly seizure, migraine, hypoglycemia, or maybe even something neurological like a Bell's palsy. Images of the head is consistent with acute ischemic stroke, not a hemorrhagic or brain tumor. So all these criteria are very important when determining if a patient should use TPA. Exclusions. History of diabetes, stroke, intracranial hemorrhage, or serious head trauma. Major surgery within 13 days. A systolic blood pressure above 185 and a diastolic blood pressure above 110. Rapidly improving or minor symptoms. Recent acute MI. Clinical manifestation of a subarachnoid hemorrhage. Active internal bleeding within the last 21 days increases the blood risk, or any type of coagulation disorders, which we discussed earlier. And labs can help to determine that, such as D-dimer, as well as platelets and INR levels. Hypoglycemia, and if the patient is above the age of 80, they are not a candidate for TPA. Management of a hemorrhagic stroke or a brain bleed. So the management of hemorrhagic stroke is very similar to ischemic stroke with a few exceptions. So the control of the patient's blood pressure, weight loss, stopping the use of illicit drugs, alcohol, tobacco, managing their sodium intake, compliance with cholesterol-lowering medications, as well as arrhythmic drugs and hypertension, antihypertensive drugs are necessary as well. One major difference is TPA cannot be used in a hemorrhagic stroke or a brain bleed. This is very important to know. No anticoagulants or antiplatelet drugs can be used if anyone that has a history of or is suspected of having a brain bleed or a hemorrhagic stroke. Surgical management include aneurysm clipping, and to my right you can see a picture of that titanium clip that is placed on the aneurysm, as well as an aneurysm coil. And there is it is a picture to the right as well that shows a coil that prevents the blood flow into that cavity in the artery from the weakening of the wall, preventing the rupture of that artery. Nursing management. So let's begin talking about nursing care and how are we going to care for our patient. So this can be found in your textbook on page, I believe it's 1354. And this is box 47-1. So these are the stroke chain of survival, or the 7 Ds. So this is just the steps in order to get your patient the proper treatment in the proper time frame. So number 1, you want to detect the symptoms signs and symptoms of an acute stroke immediately. So once you detect these signs and symptoms, call 911 because it is important to get them to the hospital as soon as possible, because if it is an ischemic stroke, then they may qualify for the clot busting drug, the TPA, but we have to determine if it's ischemic or hemorrhagic in nature before any treatment can be administered. So signs and symptoms are detected. That's number one. Dispatch of EMS by calling 911. That's number two. Number three, delivery of the patient to the medical facility. So the patient should arrive to the medical facility. And four, door of the emergency department. So they should arrive to the emergency department, and immediately upon arrival, a neurological assessment should be completed. You want to note the time of onset. And number five is data collection. So a CAT scan would be done immediately, along with a series of neurological exams. Once it is determined that the patient has an ischemic stroke or a hemorrhagic stroke, then the treatment will be determined, and that is step 6. In the event that it is an ischemic stroke, meaning it was caused by a clot, either an embolism or a thrombus, the TPA can be given within 3 to 4 hours, ideally 3 hours of onset of symptoms. Okay. In the event that it is a hemorrhagic stroke, TPA or a clot busting drug cannot be given because the patient is already bleeding out in their cerebral area, and any anticoagulants, any blood thinners, definitely a clot busting drug will cause a hemorrhage in the brain to worsen and possibly be lethal for that patient. Step number 7, or the 7th D, is drug administration. So if the patient is determined to have an ischemic stroke, which is the most prevalent stroke, 80% of our patients have ischemic strokes, then the clot busting drug will be given if, in fact, the onset of symptoms was within 3 to 4 hours. Emergent response, stroke. There's treatment if you act fast. So this is an acronym, FAST, which gives us a reminder of the things that are vitally important for a stroke patient or a patient suspected of having a stroke, and helps us to do a very quick assessment. FACE, which stands for F in FAST. Does the face look uneven? And often the nurse will ask the patient to smile. And sometimes you don't need to smile just to see the droop. Arm stands for A in FAST. One arm hang lower than the other. If you ask the patient to raise their arm, one drifts. S in FAST stands for speech. So often there is slurred speech, or you will ask them to repeat a word and they are unable to repeat that word. They say something totally different. And sometimes they are unable to speak at all, or word finding may be an issue. T stands for time. So it is important to remember that it is an emergent event and you must act now. It is important to call 911 and to have them taken to an acute care setting for treatment as soon as possible, because as I explained, treatment depends on the timeline, and most stroke protocols have a time frame in which they can actually administer the TPA, and they have to get a CAT scan first in order to state that this patient is appropriate for TPA, or an MRI to confirm that it's an ischemic stroke versus a hemorrhagic stroke. Nursing care and assessment for an ischemic and a hemorrhagic stroke. Our first priority is always maintain a patent airway. The patient's oxygen saturation must be 92% or above. The head of the bed should be elevated between a 25 and 30-degree angle to promote venous drainage. Safety awareness is a concern for these patients as they have paralysis. Often they have a neglect of one side of their body and also sometimes just a weakness or impulsivity. Therefore, falls and injuries are a primary concern for these patients. Also, choking and swallowing difficulties is a primary concern for these patients. Therefore, a speech evaluation should be done as soon as possible to evaluate for dysphagia. The patients may present with some drooling because they are unable to manage their oral secretions, and their diet will be downgraded to a puree or soft diet to prevent any aspiration as well as choking, and the liquids will be thickened until the speech therapist or a swallowing evaluation is done to clear them of any signs and symptoms of dysphagia. The nurse will complete a assessment as well as a complete history on the patient, determining their medical history, any current medications they're taking, really looking for any blood thinners or antiplatelet drugs that could have contributed to the CVA, any allergies, their current weight. We will check their blood sugar just to rule out hypoglycemia, as well as a full set of vital signs, and they will be monitored frequently, as well as we will interview them asking about their history for smoking, illicit drug use, and alcohol use. This history will give us an idea of whether some modifiable risk factors have contributed to their current condition. The nurse should be prepared to complete a neuro assessment, a cranial nerve assessment of all 12 cranial nerves, as well as complete their facilities policy neuro checks or neural assessment that's in place. Monitoring of the heart rhythm is essential, as AFib or sometimes another arrhythmia such as a flutter may be a causative factor. Good skin hygiene is also essential to prevent skin breakdown due to their impaired mobility, and patient teaching is critical because this is a new diagnosis. It's also often very frightening for the patient and their loved ones, as well as the loss of mobility or control of their bodily functions can be very intimidating for someone that was fairly independent. And also, if in fact your patient is post-operative because of carotid artery surgery, post-operative monitoring is necessary as well. Complications related to a CVA. So the most drastic complication is a stroke can result in death. And for almost 50% of the CVAs that occur, they do result in death. Temporary or permanent disabilities include dysphagia and aspiration, which we discussed what they were. It is important to maintain their airway. Weakness or paralysis of the extremity. Muscle contractures associated with weakness. That's why it is important to continue range of motion and rehabilitation between OT and PT to decrease muscle contraction. neglect or inattention of one side of the body, visual deficits on one side of the body, disorders of speech, disturbances in planning, um, any type of motor activity. So sometimes they're impulsive with their movements. Other times they are unable to control their movements, which is called ataxia. And sometimes their awareness of this results in depression and anxiety due to the need to depend on others. Gerontology considerations. So elderly are more at risk for CVA. Anyone above the age of 55 is definitely a higher risk. And risk factors that elderly usually have present are hypertension and their adherence to taking an antihypertensive drug. Sometimes it is a cost factor and they are unable to afford the medication. And so it is essential for the medical staff to investigate this possibility and to help find resources to get them the medication that they need. Other times the elderly are unable to manage their medication and they may need a caregiver to help set up their pill regimen for the week. And that's something that either a loved one can be trained to do, or social service could arrange for a nurse or an aide to stop in and manage their medications for them on a weekly basis or daily if needed. Healthy eating. Often elderly are unable to cook for themselves, and therefore they have a lot of prepackaged meals which are high in sodium, and these hidden sodiums sometimes increase their blood pressure and place them at a higher risk for a CVA. So some of the symptoms that occur, elderly sometimes will overlook and will not report them immediately. So decreased alertness, drowsiness, weakness, falling, they will attribute these things to just being older and aging, the aging process. And this delay in care sometimes put them at a higher risk for an imminent death. Patient teaching. So we want to teach our patients upon discharge, especially our new CVA patients, the disease process, any warning signs, the importance of the timeline and notifying the emergency medical system or first responders immediately. Also, we want to emphasize lifestyle changes will help minimize the risk of a reoccurrence of a CVA. So we want to encourage them to exercise, to eat a low sodium or no added salt diet, typically 1,500 milligrams or less. We want them to modify their drinking and smoking habits, if not, cease them. We want to encourage medication compliance to prevent strokes. So any arrhythmic drugs, any blood thinners for those with ischemia or ischemic strokes. And we want to also encourage antihypertensive medications to prevent vessels from rupturing, causing a hemorrhagic stroke. Safety. So we want to make sure that our patients is compliant with their diet texture. That is very important, because it could be a choking hazard, as well as the consistency of the liquid that they're drinking. The patients must take small bites when they're consuming their meal, as well as sit upright when eating and drinking. These are all important because the muscles associated with swallowing may be impaired due to the CVA. Self-care. So we want to educate the caregiver as well as the patient that the side that's affected by the stroke should be dressed first, and then the side that's unaffected. So this is common knowledge for nurses, but this is not common knowledge for a layman. And we want them to provide special attention to the affected side and not to overlook the affected side, but to take special care and protect the side that is weak or paralyzed to prevent further injury. In summary, CVAs are largely divided into two categories: hemorrhagic and ischemic. Strokes can vary depending upon the area in which the brain is deprived of oxygen and nutrients. Hemorrhagic strokes are usually a sudden onset and a persistent headache. Ischemic strokes are more of a gradual onset. Strokes are confirmed with brain imaging, physical assessment, and patient history. TIAs are also known as mini strokes, and they are a warning of a pending stroke. Hypoglycemia and Bell's palsy may resemble a stroke. A good assessment and medical history is essential to rule them out.